Welcome back, everyone, to our Unclenched podcast. Today, we are going to be talking to a Postural Restoration Institute, PRI, physical therapist, Dr. Emily Iverson. Dr. Iverson has worked with me and before me, my amazing mentor, Dr. Arthur Parker. And together, we have gotten phenomenal results for our wonderful patients. Before we get started, though, you all know I always need to get caught up with my Alex. So, what is up? What's been happening? And I want to hear about a patient that you've recently treated. So, tell me what's going on, Miss Alex.
Oh my gosh, just so busy. We've had a fantastic year. We were just so many great things have been happening with my family, the kids. I'm just truly blessed, but yeah, it's been a great year. I was just talking to my husband last night and I'm like, I cannot believe what I'm seeing in my practice still and how excited I get to go to work and 35 years is a long time to still be excited about getting in there and getting my fingers dirty. But one patient, though, that was on my mind right before we started, his name is Justin, and he owned a Chinese restaurant for a long time. He and his, I think, family, but he came to me because he had severe headaches, head pain, neck pain, the regular things everybody always comes to us with, and tingling in his fingertips, just everything, bad sleep. And so he was in last week or the beginning of this week, it might have been. And he comes in and his eyes are like wide open. He's got a little more pep to his step. So we got rid of his headaches. Go through the whole list. Everything looks so great. And he said to me that, I'm like, Danielle said to me, it seems like we're more excited that he's feeling so good than he is. I'm like, what is wrong? And he's like, I still have a little bit of brain fog. And I'm like, oh my God, out of 25 things, we have one little thing left. Because I always tell my patients, if there's something I can't help you with, I'll try to find a provider that can. If something changed, maybe it's not TMD or TMJ related and it's something else. So I knew from his intake history that he had a traumatic birth and going through the birth canal. He was a really big baby, I think 13 pounds. And this was back in China. And so his mom was in labor for 30 some hours, like just horrific. And I'm like, well, maybe something's going on from when you came through the birth canal and we need to look at the cranial bones and which I can't do. So today he's at a cranial sacral therapist, which I recommended and I work with a lot. And so I'm so excited to get the call from her later today to see how he's doing, because when you think of all that trauma going through the birth canal and all those hours, and then even probably emotional trauma to him because his mom still says like how difficult of a birth he was. So he probably just thinks like, oh my God, I hurt my mother, or just there's probably a lot of deeper issues that I'm not trained to go into. But when you keep thinking about it, you think of all these things. And I know that the cranial sacral can help with the emotional issues or any baggage like that can go on to. So we got him great. I'm happy with the progress, but he's hanging on to that one thing, which is big to him. So we're going to try to help him with that. And hopefully I'll have an update to see,
Yeah, let me know.
Yeah. Yeah. So I'm excited for him. Really excited.
Definitely keep me posted.
Yeah. So what about you? What's up with you? Who've you seen? Who sticks out to you? How are you?
Yeah. Well, yeah, everything's good here. Kiddos are growing. We're super busy. And one patient, I guess, that sticks out to me is the patient who came to me with disc displacement without reduction. And as we've treated him, his bite he's unlocked now. So his jaw was locked closed. He could barely open, was in a lot of pain. Now he's unlocked. He's out of pain, but he has developed a bilateral, so both sides, posterior back teeth open bite, which can happen, right? Like the way the teeth come together in the first place was sort of causing his locking or caused the condition. So now that he's recaptured the disc, the jaw has sort of dropped down and forward, and he's happy in that position, but he has an open bite on both sides in the back. And so it's kind of an interesting time. And I told him this could happen before he went into treatment. So he's not like shocked or upset by any means. It can
Yeah.
certainly happen. Um, but it's sort of an interesting time for my practice because my husband is getting trained in full mouth reconstruction and in the neuromuscular ortho with Jen Stafford and Martin
Hmm.
Machete. So it's sort of an interesting time because I think by the time he's like done with treatment, out of pain, stable, he's going to want to transition into that phase 2 treatment where we stabilize his bite. And um, it'll be a great thing for all of us when we can get him his bite back and in a position where the joints and muscles are stable and healthy too.
So
So
what do you
that's
have in there now? An orthotic? So
yeah,
he has posterior contact? Yeah.
yeah. He has the contact with the orthotic in.
Yeah, yeah,
It's
yeah,
just,
yeah,
but as soon as he takes it
yeah.
out, his
Oh, yeah.
bite's like
Gonzo.
not
Right.
happening.
Yeah.
It's not
Yeah.
happening. It's not having it. So
Gotcha.
so yeah, so that's been an interesting one to guide through this treatment, and we'll see what phase 2 holds for us. But yeah, so let's bring in our guest today, physical therapist Dr. Emily Iverson. Dr. Iverson earned her doctorate in physical therapy from the University of Minnesota. During that time, she received postural restoration therapy for herself, which was very life changing for her. And she took her first PRI course, again, Postural Restoration Institute course, before graduating, and was the first provider certified by the Institute here on the West Coast. So that's really cool. She's also certified in craniosacral therapy and yoga therapy, and she opened her practice Shine Integrative Physical Therapy in 2009 here in Portland, Oregon. So, welcome, Dr. Emily.
Thank you. Thanks
Welcome.
for having me, ladies. What a treat.
Yeah.
Sorry, no Halloween pun intended there.
What a treat. Yeah, on Halloween.
It is a treat to meet you both.
Oh.
Thank you.
Well, so I've heard a lot of great things about you, but something you might not know about me, Priya, but I did my 200 hours in yoga.
Oh, yeah.
Yeah, because I did this a few years back because I know yoga's so good for you, and in the way different twists and turns. I wanted to know what organ I was working on and all that kind of stuff. I've never taught a class, but I did finish the program and get my 200 hours. But anyway, this isn't about me. This is about Emily. So
Holistic team here. That's great.
yeah,
I
yeah,
love it all.
yeah. So what exactly is postural restoration physical therapy, and just explain a little bit about that for us.
Absolutely. Yeah. PRI, Postural Restoration Institute, I've heard the founder say a few times he kind of wishes he could rename it at this point because a lot of folks hear that word posture and they immediately are like, oh, military posture, and this therapist is going to tell me to stand up straight and that hurts. And I know that. But postural restoration, when you think about where Ron Hruska, who actually went to dental school and then moved on to PT school, um, took this term was just because we want to consider all the systems that influence posture. Um, so we could list everything, right? I mean, obviously, physical therapists, dentists, osteopaths, chiropractors, we generally hang out with the musculoskeletal system, and that's great. But there's so many other systems that influence posture. Certainly in my realm, I really love the nerve work. The nervous system rules everything. Nerves and arteries run together. So arterial work is very important when we're thinking about manual therapy. The organs play a massive role. PRI is what brought me into the visceral world and studied with Jean-Pierre Barral of the Barral Institute. And those treatments can fix things sometimes, not always, but moving a liver that was stuck after a car accident and getting that mobility back can allow that person to breathe better, rotate their trunk better, and their neck and jaw might feel great from a treatment very far away. Of course, the endocrine system's involved with the visceral and organ work there too, and on those functions. But we certainly consider vision massively. We'll talk about that later, I know. And I think where PRI really shines, though, above all other therapy frameworks, is breathing. My first course out of school was If You Can't Breathe, You Can't Function by Mary Mastery. And she's a PT who I don't know if is still teaching, but she really brought it to pediatric neurological therapists, how important the breath is. And so we talked about pressure in the thorax and all these great concepts. But even with isolated breathing treatments like Buteyko and other really good styles of therapy out there, they don't incorporate all the other systems and they don't look at a lot of the asymmetries in the body. So I think that's what really stands out to me when I think about PRI is the first course that Ron Huruska taught was postural respiration. It's changed its name a few times and split into many more courses now. But looking at the asymmetrical two sides of the diaphragm and how they influence posture, digestion, our nervous system, therefore our autonomics, our entire spine, and therefore our jaw and vision and all the sensory systems in our heads, right? So PRI has a lot to offer just from that big, broad viewpoint. And I think that's daunting to some therapists. It's why a lot of folks come to courses and don't come back. It's a hard treatment approach to dabble in. I myself worked in PRI and an orthopedic clinic for many years, and folks would compliment me on my outcomes for my patients, but they also thought I was doing like a fascial release on a diaphragm, and they weren't thinking about the neurology behind what we were doing. And so we definitely really invite all other therapies in, joint mobilizations, craniosacral, primitive reflex integration, all kinds of hands-on work. But it's a template, right, that really, again, takes into consideration all the systems that affect posture. And certainly if you can't breathe, you can't function, and you're not going to have great posture. So I think that's one key point. Yeah.
Emily, this is a little off script, so forgive me, but I
Really
got
good.
curious as to like when you got treated by postural restoration therapy, what were they treating you for? If you're comfortable sharing that.
Oh, absolutely. Yeah. It's actually on an interview on the Institute. I have a number of yoga articles on there too, Alex, if you're interested. Um, yeah, I'm a really good example of somebody that probably should be a burned out clinician and a burned out person, frankly. I've had so many orthopedic injuries as a hypermobile individual, which now is a very much more known diagnosis as far as connective tissues disorder go. But I mean, there were times I thought, I don't know what's wrong with me and why I keep tearing things and hurting myself so quickly. Tore my lateral meniscus, probably from getting on a bike clip in college. I was pre-med at the time. My knee was swollen. I couldn't put my pants on the next day, and I
Oh,
was
wow.
misdiagnosed by an orthopedic surgeon. Unfortunately, that really changed my career trajectory at that point. I did not feel heard. I did not feel like I was really looked at as a person who was an athlete and in a lot of pain and could barely walk into this person's office. But I was sent to physical therapy, and the physical therapist was amazing, very holistic, way more my style. Realized I didn't really want to be in a surgery suite anyway, smelling cauterized flesh, and changed my career path at that point. I went into physical therapy pre-PT, pretty much around that time frame, that month or so of physical therapy. Fast track another 6 months. I'm doing all my PT, still haven't gotten much improvement. Saw an orthopedic surgeon, went in and had that lateral meniscus tear taken out. And again, as a young, healthy athlete, didn't get any therapy again. So kind of had two strikes out with my orthopedic surgeon colleagues at that point. I've met better ones since then. Anyway, I'm now in grad school, still having knee problems. I'm cycling, I'm lifting, I'm trying to run, I'm swimming, I'm trying to be as active as I can, but my knee still hurts. And I go in for another round of physical therapy. I apologize, I did have some orthopedic PT work at OSU. But getting into PRI was a real gift because the woman I happened to work with in the University of Minnesota Physical Therapy Clinic had done her clinical at the Postural Restoration Institute in Lincoln, Nebraska. And she immediately identified the fact that I had no quad issues, which is what most PTs will tell you if you have kneecap issues. There's a whole muscle imbalance we can go into some other time. But I had awesome quads. I was cycling like 20 miles a day, and my quads were actually too strong. And she tested my hamstrings, and my leg just like went to the table. It was really humbling. So I had a massive muscle imbalance because for over a year I'd been trying to work out and rehab myself pre and post surgery with a really asymmetrical body who'd gone into a ton of pain patterning. And long story short, this woman was immediately able to get my pelvis more neutral. I felt better in my ribs. I could just feel myself more grounded and calm and confident. And I was really, really floored that she was able to identify like an out of the box mindset around why my knee was still bothering me. And I improved so much, but when she got to some of the standing exercises, I actually had some more symptoms come back, and it came to me that she had not finished her full rotation in PRI, but had learned a lot of the beginning exercises, like to get
Mhm.
people back into good position, but not
Mhm.
necessarily how to transition into higher level function. So that's when I decided to take my first course, and I was able to take my first PRI course with Ron when he was still teaching some of the core courses. And the rest is history. It just
Wow.
so
What a
yeah,
journey. Yeah.
yeah.
So in your case, do you still have to keep up with certain stretches or exercises and things
Yes,
like
ma'am.
that?
I do. Much less now. I have the trifecta. I have phenomenal PRI orthotics. And I'd be happy to chat about that at another time. They're flexible and they're custom fit, and they give me a little bit of support into my very hypermobile feet, but not too much. So they're more neurologically training me to stay in neutral. I think about those as like bumper bowling, like lanes or guide rails. So the medial and lateral aspects of a PRI orthotic give me a good sense of my parasagittal positioning, as well as like frontal weight shiftability and transfers for push
Nice.
off. So that's something I wear. I have an excellent neuro-optometrist who got me into the right alignment with my contacts. And then I have my night guards. So I do have a trifecta of the orthotics that
Right.
PRI tends to really like. And then I do a lot of my own work with checking in with my own neutrality, right? So as I'm working out, I'm making sure I'm not getting too extended or into my neck, for example. Yeah, so I do a lot to keep it integrated, but I do not feel like do not feel like I have to keep doing the exercises often at this point because I've had the help on those levels
Sure,
to keep me
sure.
neutral. Yeah,
And so I know there's a PRI course about occlusion, the way the teeth come together. And Dr. Parker took this course with you, I
yeah.
think. And immediately when he came back, he started applying the principles from the course to how we make our orthotics, how they're designed. Um, I want to take this course with you. So you and I have discussed that we might be doing that in May of next year. Can you talk a little bit about the principles in this course and specifically how the bite can affect the posture? And yeah, just tell us what you know, Emily.
I will. Well, let me back up because I did get into a little bit of my own piece, and I'll just say a couple things about PRI2 that I didn't get hit on, along with the multi-system approach and that framework. I would say too that we do look at triplanar evaluation and assessment. So we're looking at sagittal, frontal, and transverse planes, and the two sides of the body, how those can be very asymmetrical, even if it doesn't look like it. And so knowing that those patterns or chains of muscles are very either overly facilitated, which is how we'll name them, or they're under facilitated. Like in my example with my knee, my quad, hip flexors, back, and diaphragm on the left were very extended, and that's the left AIC pattern. That pushes me over to my right side, which is probably where I tore my lateral meniscus to begin with, and kept my right quad and adductor so toned. That changes the pelvic rotation and orients it to the right generally. Now, this is a very common pattern, but you cannot assume that everyone has it because a lot of us have compensated with lots of other bilateral or counter rotated positions of the pelvis. But from that sphere of the pelvis, then we go up into the rib cage, we look at the brachial chain patterns, and then into the sphere of the cranium in the temporal mandibular cervical cranial chain. And all of those have a torsion pattern to them, and many other providers see this, especially the osteopaths. Um, they just don't tend to really name it and add in the neurological respiratory component of treatment. So I just wanted to make sure we said that. The course then was actually called the cervical cranial. Oh my, which one was it? It was the cervical cranial mandibular restoration course that I took. Invited Dr. Parker to, and I have that down as 2013. And my memory of that, ladies, was I was like so popular. People, all the therapists were coming up to me like, how do you have a dentist friend? Like, how did you meet him? Like, he was the rock star in the room. And it was just really fun to be like, I just went to his clinic and I brought a patient and we hit it off. And, we have a lot of mutual respect and he wanted to come to the course. So I thought it was really humble, though, of him to come, given his status at that time, and he didn't need to go to another class. But I remember at lunch was immediately floored when we were chatting about how much of this he already saw in a lot of his CBCT scans. The torsion in the sphenoid, the torsion in the temporal bones, right? The mandible being seated poorly, and how excited he was that other providers were seeing this and offering treatment opportunities that were, holistic. So he was on board right away. I
Oh,
remember
he was
him,
so excited. Yeah.
great conversation. So that was actually a course that was for physical therapists. I think what that did, and what I would say to anyone listening that doesn't want to go into all these courses, which I would encourage you to do. But if there's something prohibitive for you around that, meeting with a dentist and just having common tests like doing passive side bending of the neck, passive rotation, passive shoulder flexion. When that person's in supine on your PT table or even on your dental chair, you get a lot of information about, how is that body feeling with their bite. I'll never
Mhm.
forget Dr. Parker putting dental wax between my teeth,
Yeah.
checking my cranial rhythm, which wasn't great at the time, and then putting the dental wax in, basically negating my occlusion, and then feeling my cranial rhythm again. It was so happy, So there are some simple ways to decide if, from a dental or a physical therapy standpoint, if someone needs some kind of occlusal support. Even subjectively, are they biting evenly, right? Do you feel both sides of your molars, etc.? So, but yeah, the course then he went on to take was a newer one, and I would encourage everyone to go to the Postural Restoration site and see all the courses that are offered. But he did take the occlusal course, and to your memory, because you were there in the practice that time, Dr. Mystery, he came back. I remember really excited about canines,
Yes.
and
That
how
was the
the
big thing, canines and feet.
yes, exactly, the
Canines and
connection.
feet. That was like the big thing. I was
You
like,
remember the
"Okay."
feet? Priya's like, I don't want to go with the feet.
It's fine. I was just like,
I
I
do.
was a little confused because I didn't come to the course. But
Right.
like, he did his best to explain it to me, but he was so excited. Yes.
Yeah. He gifted me his manual, and there are all these stars around all the connections, right? With like feet, ribs, certainly. So I would say that it just really solidified our approach together. And I would say a couple other takeaways that I think are really important for anyone. And again, you don't have to necessarily take the course to do this. If you have a night guard or a splint or any kind of orthotic device that's going to be in someone's mouth that is not just for like a deranged disc, for example, like in those situations, I know you two as experts are going to probably want that bite very stable so the disc can heal. And that would be more of an acute application of a splint. When we're talking about splints, we're helping people basically unlock, their bite, their sense of where they are. So having rotation at the canines, having a little bit of an occlusal surface, but not locking in, um, so that there's a weight shift. And you really can't sense that in the dental chair. So I think one thing Dr. Parker probably also took from the course was getting patients up to stand. So a lot of times night guards are just that. People only wear them at night, but many, many, many patients will benefit from wearing a guard throughout the day, as you both know. And so, how does that feel when you're standing up? Can you sense one side? And if you push into that side, does it shift you a little to the opposite side? Can you protrude, excuse me, laterally deviate a little bit so that there's some movement? Again, this is for someone with more of a healthy TMJ position, more of a TMD presentation. But I think him being able to look at what are some special tests that the therapist and the dentist can both use concurrently, either in the same clinic or in different situations where we're not in the same clinic at the same time, to communicate, certainly. Testing in standing and sitting to feel that sense of the ground through the head, if you will. That might sound weird to your viewers, but if you're hypermobile or have had jaw, head, or neck pain, you often don't have a good sense of where your head is. And so getting that nice, even occlusion can give you a sense of grounding and centering in your body that calms your nervous system. It helps you feel, like you have to like clench your toes or clench your jaw, right? Or clench your hands all the time to try to like sense where you are in space. So I think those principles of unlocking, being able to shift a little side to side, basically freeing up the neck, which frees up the ribs, it makes you stop having to clench into this very sensitive area where we all know we don't want to be putting excessive force into the mandible and the TMJs is something that I know I think really was able to, like you said, take away and really bring into his practice right away.
Yeah. He
So
was really excited.
one of the things before I ask my question, but one of the things that I do in my practice very, very often is once I take the bite to balance the jaw, I'll have my patients stand up and then I'll test their neck range of motion with the bite out and with my bite in, or I'll test their balance and or I'll have them test their flexibility and see how far they can rotate from the waist or touch their toes. And it's amazing because then I'll put the bite in and I'll do it. And they're like, yeah, okay, I didn't know that was coming. Do it again. So then I'll take the bite out and I'll do it. And they'll still have that restriction. But as soon as I put that bite in and I test it again, they're like, their mind is blown. They're like, what did you just do? I said, I know. And they're like, I can turn my neck more. I can, and so many of my patients have said, like when they're driving and they have their orthotic in, which my patients wear it 24/7. I'm a believer, and this is just my opinion, but I'm a believer that when you do something during functioning hours, you still need stability. So night you're resting, you don't need as much stability, but you need it more in the daytime, I think, than at nighttime. So I am like, you wear it 24/7. You could take it out to clean or what have you, or you get your teeth fixed or whatever the options are to get their bite straight. But it is amazing on how different it can be, or even what I've done with patients too in consults when I see that their hips are off, sometimes I'll put a tongue blade in on the one side where the hip is higher, have them go outside, walk down the steps, come back in, and then guess what? Their hips are back on. And they're like, "Alex, I felt it go back in. I felt my hip." I said, "I know. Now we got to
They're like,
find the
what
break."
voodoo are you doing?
I know. I love it. Little Halloween voodoo. But
I know.
anyway,
Well,
I think that's really, really important to know the connection. But my question is how, if a patient isn't equilibrized or biting properly, or has one condyle that's set back, not displaced, but just set back more, and that way it torques the whole mandible. How can you do your work and keep it there without also having the assistance of an orthotic?
Well, you can't always, certainly.
Because I would think the muscles would just
But
coil up to where the teeth come together. That's what's going to stop it,
that's right.
right?
It's interesting, I tend to, and I don't know if I have like some little energetic lighthouse out there. Like I'm hypermobile.
Mhm.
I've probably had the same thing. You
Those
have
are
had
the hardest
concussions. I've had to,
patients.
I do put it on my site that I do try to treat a lot of different things. And so I don't know how, but folks find me that have a lot of the same issues. And so I'm very biased in that, I've worked in orthopedic clinics where you didn't even look at this, right? Someone came in with neck stuff, we stretched them, we gave them some things, we elbowed them, whatever, all the good orthopedic stuff. And that works on a lot of people, right? It didn't work on me. None of those types of traditional orthopedic things work. So I think, we're in a subset, obviously, as very critical thinkers who see very complex clients with chronic pain. And so there's folks out there that, there bite may be terrible and they still feel better and they don't have headaches and, God
Sure,
bless them.
sure.
But
Right.
the folks that we see, I would say the thing I do that's a little different than what I've been trained in is I try to triage immediately. I try to check in with visual function in a number of tests and measures, as well as occlusal sense and any information that might want me to, or, encourage me to say, I may not get you up. I told Priya this a while ago. I think of that Chutes and Ladders game as a kid. I
Yeah.
always want to get that one ladder. So they're like out of here and you're done and you go have a wonderful life and you come see me once in a while or bring your kids in, for some cranial sacral or something. But I don't want you to go through 6 visits, which is pretty traditional, and then decide if you're going to make progress or not. So I also have to judge that on people that have come in and have seen a lot of healthcare
Yeah.
providers, and I don't want to overwhelm them. They may be out of budget for healthcare, at that point. So where I'm going is I'm trying to really get that full 75 minutes or more I have with my first patient eval to get a sense of where's this person? Are they ready to talk about dentistry? And they clearly have a narrow bite or cross bite and they need that, or can they just literally not kind of chew and swallow on that right now, right? So I try to think about, and that's where like aqualizers came in a lot. I know Dr. Mystery and I have used part of it, right? So maybe we try that and we do some PT exercises and some manual. But yeah, to your point, so I firmly believe that the body, or back to your question, I firmly believe that the body is capable of realigning itself for the most part, especially if you're younger, especially if you're hypermobile. And the hypermobile people that come to my clinic, which is the bulk of my patient population, have already compensated to the nth degree, right? They've adapted and tried their best to do the rows the PT told them, or do the back bends, or sit up straight.
Sure.
And they love when I tell them to relax and exhale and protract and get their diaphragm down. And then their C spine curve comes back. And then their temporal bones realign in a way that actually seats their jaw better. So sometimes just getting out of constant extension, and again, that might be a primitive reflex treatment we add in, as well as like a neural dural glide, for example. But regardless, when you can get someone out of that extended, like sternal reflex, get them to be centered in their body, start to learn that they can weight shift. They have 2 sides. Like me, they don't have to stand on the right leg, even though it hurts.
That's all I do, is stand
We
on my
can
right.
unlock, right? We can
Yeah.
unlock. And I firmly believe, because I feel it every day I touch someone's head, that temporal bones move, right? They have a beveled surface. They rotate and flex and extend and ab and adduct, just like an ilium. And they can change. And so, as a PT who is great at dental work, relatively speaking, but not a dentist, I feel our power is to come up, and I think about it often as flipping the pyramid back. So a lot of people will get very tense in their neck from autonomic dysfunction. And that could have a lot to do with structural airway or an actual disc problem. But let's say they're somewhat amenable to getting out of this position. Okay. So the subset we're talking about are people that aren't like acutely dislocating. They're a disc, for example. So they're walking in, they can chew, they're doing pretty well, but they're hurting. Those folks can often come in as holding themselves up with their upper body. And I think about like someone that's flipped a pyramid, right? Then they're going to yoga and they're being told, well, your hips are tight, or go to yoga and stretch your hamstrings out. And now they're so loose, that bottom part of the pyramid is not meant to be this tippy point, right? And so their pelvis is going to lock into further extension, which is going to make their diaphragm stay in an inhaled position. And they're going to use their accessory neck muscles to breathe all the time. So we often tell these folks, stretch your neck, stretch your hamstrings. And without getting off on a huge tangent there, you can see the error in that, right? And so what I try to do is think, how can I get that person grounded again? Maybe they just need some decent shoes. Maybe they need to feel an exhale and their abs are actually strong. Their glutes and hamstrings can balance themselves out. And now we've got them at least in some sagittal neutrality. That's going to allow their ribs to settle back down in the front, regain good diaphragmatic movement, and their neck and jaw will have a place to land. And so
Right.
then the temporal bones have a chance, to actually start moving in some symmetry, or synchrony. And then we can move from there and see if that mandible torque really is the source, or is it an outcome of full body, malalignment, maladaptive positioning.
Well, let
Does
me
that make
ask you this. When you kind of unlock those temporals, you get them moving properly or freely, and then the mandible sort of seats. Do people tell you I feel like my bite's changed?
I try to ask that, but yeah, sometimes that does come up spontaneously. And that's where things like, Rockabato and really obviously like
Love
jaw opening, closing,
Rockabotto.
right? All those principles. Then I try to instill those. And so yeah, some folks can do really well without dentists and some folks can do really well without PTs, but I do think a lot of our clientele, obviously, as I know from listening to your podcast, they need the village.
Sure.
But yeah, I think the body a lot of times, especially in those more loose connective tissue folks, can come out of poor jaw positioning if we catch them early. Or like our most recent client that Dr. Mystery and I shared, Erin, was someone who would never have done well with me initially. She absolutely needed your care. She came in much more stable, not afraid to open her mouth, and then she just like we
I mean, she
cruised.
couldn't even eat when I saw her. She was in so
Yes,
much
and now
pain.
she's doing so well because she feels safe. Her nervous system knows her jaw is stable, and she's a
Yeah.
very hypermobile individual, but she's able to do some of the exercises and get a little more calm in her body and start moving again. And that's really the whole goal. So
Well,
resting well, breathing well.
can you tell us how PRIPT work helps to treat the TMJ problem specifically?
Yeah, that was such a great question. I think the big picture that I was sharing about earlier is just, how the jaw is at the top of the neck.
Right.
So getting the neck, the breathing muscles, certainly as happy as they can be, not feeling like you're being running from a lion, right? And your accessory muscles are working all the time. So definitely the biggest piece I would say to that question would be getting out of those extension patterns and those asymmetries that are creating indirectly torque into the TMJs and certainly creating TMD dysfunction as well. Optimizing breathing is a huge part of that. I already
Mhm.
discussed. Yeah, feeling that autonomic safety again, feeling like, and I will mention one key thing about PRI that I love is when I work with the client, especially with the head or neck symptomology, there's so much fear. They don't want their jaw to displace again. They don't want to have headaches every morning. They don't want their nerve pinching down into their neck. And so what I love about the framework of PRI is it gives the provider and the patient really easy tools, relatively speaking, to assess where that person is. Are you neutral or not? That empowers that patient to then feel, okay, when I'm neutral, I feel my back a little, I feel my neck working a little, but it's not like taking over the world, right? And I can do these exercises to feel like I get back to neutral, and my provider can see that that objectively is true. So now they have a home base. Now they can come back and go, okay, if I do these drills, maybe even before they see you guys, right, to get their bite registry or whatever, they feel empowered to be more neutral, and then they can do those techniques again. Unlike exercises where you just do a bunch of rows or stretches, that doesn't always give that person feedback as to whether they are in a good aligned position. It might flare up. You might be like, as the Chinese medicine folks I love studying with, they'll say, they say circle the dragon, right? Don't go poke at that neck that's already working so hard. I mean, get a massage or a cranial or whatever if you need to. But if you go and just stretch that, you're not really getting to the why. Why is that tight? Why is that continuing to work? So when a patient becomes empowered to inhibit like a neck muscle that's hurting them, doing drills that maybe aren't even in that area, like circling the dragon around the hips or the now they can like calm their system down and go, hey, I'm going to help myself, but not go right to what already hurts, which, can obviously exacerbate things. So I think that's a really unique framework to come in from when someone, especially, we know with TMJ, especially, it can be, and headaches can just be so depressing and anxiety filled. I've been there. Um, Even thinking about like rubbing my head if I have a migraine is like, no, don't touch me, right? So how do I come in and help my whole body realign without maybe exacerbating that spot that's already kind of in a victim place? Yeah, I will say two things. We have some excellent orthotics that PRI uses, and they have really fun positioning. I brought out my awesome day one from Dr. Parker. This is an older little great one that I
That's
still
the
use.
OG. Yeah.
Yeah. So this would be a lot like the mandibular molar occlusal orthotic, the MMOO in a way, because it's giving me good molar contact, but like a nice day guard, I can still speak pretty well. And so I can articulate my tongue. it's helping me ground my molars. They give me that sense of bilateral of referencing base of my neck into my spine. So really good principle there that Dr. Parker was already using. And then the MOO itself, the mandibular occipital occlusal orthotic, as an example here. Um, Dr. Priya, I was looking at my husband's earlier, his night guard, and I noticed the difference between the PRI one and his is there's a little more of this ridge. And so what the PRI dentist allowed for this one to do is give me a lot more movement because I was doing better, right? So I needed Dr. Parker's more occlusal bite, a little more of a rigid guideline. Emily, let's get you lined up. Let's stay there. And then this one has much less occlusal surface as far as like a bite imprint. It still gives me more of a range of where my neutral is, but allows me to move. And I find that I don't clench as much in that one because I'm not locked into
Interesting.
one
Yeah, because
spot.
you're not locked into those bite indexes. I'd
And
love to
again,
see
that would
that
be
in
for someone
person.
that's doing better. And I like the analogy of maybe like not walking around with blinders on, like or having too strong of a reference point. Some folks need that, and there are certain aspects of a treatment plan that I know that's vital. And but as people progress out of that and they get more neutrality, we want to teach
Yeah.
them to move, to occlude and disclude, right? And to
Yeah.
weight shift, even in
There
their head.
there are
So they're just able
certain
to walk too, right?
yeah, there are certain neuromuscular guards too that do the same kind of thing. It's like one is I've learned from Jay Gerber is a pull forward appliance to keep you forward and you function in that for 2 weeks and it's almost just like an up and down and it doesn't
Okay.
allow you go laterally, but then in a couple weeks time you take that away, those walls away and make it more flat and just dot occlusion. And a
Yeah.
lot of times that works on patients. It's like 2 weeks one way, then like you, but we just use the same orthotic and kind of flatten that out.
Beautiful. Yeah.
Yeah,
Give people more freedom, right? You need
exactly.
references to be safe and neutral, and then you want your patient to get stronger and move through that. So they can always come back to
Exactly.
home, but they can go out of town too,
Yeah, yeah.
not fall apart. Yeah, that's great. Yeah, I don't think any of these necessarily, and I can't speak for Ron as a dentist myself. I think these are all coming from collaboration with other dentists.
Sure.
I know he has a very strong team of dental colleagues in Nebraska that he works with. And so, what works? What's the science that you guys are using? How are you tensing or using the different techniques to get into neutral bite? They're all going to get us up the hill. I
Mhm.
think what's great about, right, and there's different trails to go up that hill. But what I like about any approach, even if it's, just checking cranial rhythm with a cranial sacral therapist with your splint on, how's that feel? You
Sure.
know, that's collaboration right there. Just calling
Right,
up that provider and asking, what did you find with my intervention? Do you have any
right,
feedback for me? Right. It doesn't have to be this one paradigm that is driving it.
Well,
right.
can you share with our audience, I think they'd be interested to hear this, how you and Dr. Parker and I actually used to work together on patients? Like, I know you and Dr. Parker did it more. He would do, like, soft tissue manipulation and cranial work from the cranium, right? And then you worked on different areas, and I think people would just and at the same time, so it's like you would come to our office. I think he would even go to yours at some point before I entered
Yeah.
the picture.
Yeah. That was
And
a
I just think people would love to hear about that.
Yeah, I love this. I love thinking about that. It was a really special time for me. I think, especially, I had enjoyed listening to Dr. Parker's podcast with you all, and I don't even think I knew like what genius I was working with at that time. I mean, I knew right away what a humble and beautiful person he was, and how smart and obviously very open minded. But um, yeah, to hear his history and how much he was not really supported in the community just
It
made me
was
so proud of him
awful.
that he, yeah, kept persisting and just has such a beautiful heart. And I'll never forget him helping me after the car accident, how much empathy he, brought to me. And he was really the first person that said, you really hit your head hard. Like, this is bad. And I just really needed that because I think as someone who is a strong woman who wants to be well and try not to, get too down on herself. Like, I actually broke a tooth and had multiple root canals because of the trauma from that car accident. Now, I had his night guard in when I was hit. And I swear that's probably saved my tooth and
Sure.
had much more trauma.
Oh,
So I'm always
interesting. You had it in.
I did. I love driving with it. Yeah.
A lot of
I
my patients say that. They still drive with
absolutely.
their orthotics, and then I had one patient wear it when she went into labor.
Oh, brilliant. Yes. Great. Yes, do that.
Sorry.
Uh,
Sorry, go ahead.
absolutely. Yeah. So I like to work out with mine, etc. So personally, as you know, with that aside, I know what an amazing human I was working with at the time, but then to hear that podcast really brought it home to what he persevered. Yeah, I met with him and we hit it off with a patient. Um, and I think he enjoyed me coming over with patients to his clinic and collaborating when I could. When I started my own practice, I was able to do that a little bit more. But pretty soon, he actually, I really think, I can't speak for him, but I think he was seeing what the postural restoration work and the visceral and neural work was doing. And so he did start off doing a lot more of the cranial and soft tissue. But honestly, my memory of when he would come to my clinic, is I would have patients run through their programming, inhibit their anterior neck or their upper traps or whatever exercises we were doing from PRI, maybe some other manual. But then they'd walk across the hallway and he would adjust the night guard, and he didn't find that he needed to do much manual is my memory. So I think that's part of why he liked coming over. Was it was really fun for him to see the patients that we were sharing improve.
Yeah,
um,
from what I recall, like, I would adjust the orthotic and you would check the cranial rhythm and
that's
do
what we
some
did.
therapy.
Yeah,
Okay, okay,
that's
okay.
right.
Alright, so
Yeah,
I
and
think my memory.
that's a really strong memory of you. Besides you giving me my first mask when COVID hit, I didn't have any masks, and I asked you at the end of our appointment with my husband, "Do you have any masks?" And you were so
I
sweet.
don't
You brought
even
out some masks.
I
I
don't
thought
even
I won't
remember
need
that.
these.
Yeah.
Anyway, you're all big-hearted people. But yeah, when Josh came in, my husband came in to work with you and Dr. Parker. I remember that day, and you just would get the bite into an even place, and I would check the cranial rhythm. I think we
Yeah.
did it a few times, maybe
Yeah.
3 or
We did it,
4.
like, 2 or 3 times, and then like, after that, you were like, "This is really good," and then I never saw him again. I don't even think I had to see him again, but I am so sad that so when Doctor Parker retired, you moved further south and I moved further north. So it's, like,
Oh,
so hard for us to get together now and work with patients, but it's so
how far
beneficial.
apart are you? Are you two?
With traffic?
Yeah, I was gonna say that's that's
How
the
far is
asterisk
it?
there, my friend. It's like
Like,
LA. Oh, it's only 10 miles. No, it's gonna
no.
take you 2 hours. Yeah.
Yeah, it's, like, 2 hours, and with traffic, it's really bad, and so, I know, and when Doctor Parker retired, he said, "Do not forget about Emily. Like, she is a valuable resource. She's helped so many of our patients. Just because, like, she's moving and you're moving, like, don't forget." And I didn't forget. It just things got so busy that it just hasn't happened, but we've reconnected. We're gonna, like, do better about working together, but I did wanna ask you, or I think Alex was gonna ask the next question.
I will say one last thing, and that is, if you don't have the luxury of having your own practice where you can like drive to a dental clinic or have a semi-retired dentist, guru come to yours. I do think that's where like some of those tests and measures I was mentioning, cranial rhythm, passive range of motion of the neck. I certainly find the gold standard for me is OA side bending. Right. So if you can just stabilize C1 and get a couple degrees of side bending to the right and left at OA,
Mhm.
right?
Like
Your
this?
night guard's right? Yeah, a little
Yeah,
Bollywood. You're
I
you're
know.
probably you're probably like in a really good position with your night guard. So having a couple key tests and measures that you can go back and have, or even like a video of the patient walking, like the dentist
Mhm.
could send that to the PT. Maybe they're not even in the same town. And like there are ways you can start to have right communication pieces that you
Sure.
can then say, and I'm seeing them lose left side bending of their neck, or they're starting to come in with a really elevated right shoulder.
Yeah.
And so even if you have a client, within I think 36, 48 hours, maybe try to see both of the providers. I still think that can work really well. And there are other creative ways I'm sure that people um, collaborate. But yeah, I do realize that like, especially to your point, like it's impossible um, to try to drive up to one another's clinics. And I'm sure there are a lot of other
Yeah,
prohibitive
not
things
during
too.
business hours. I could come to your place on a Saturday, but not
Yeah,
during business
right? And then
hours.
not see your family and,
I
yeah.
know. I know, it's
Yeah.
just too much.
Yeah. Well,
Patients
can you
understand. I think they're also grateful that we're even, like, open and interested enough to find these ways to work together, that
I know.
they're willing
I
to,
know.
and it's not forever,
Yeah.
right?
Right.
Right.
So, can you explain what neuro-optometry is and how it relates to TMJ problems and posture?
I will do my best. I love neuro-optometry so much. I think, when you think about neuro-optometry, you can also look up behavioral or developmental optometry. So these are folks that are high-level allied healthcare optometrists. They already have their doctoral degree, and they're going into further training to help kids often with, like, learning disabilities, um, ADHD, things like that, to help with the development of posture, of vision. I will say, if I don't forget, looking up someone with a COVD after their name. I think that's College of Visual Development. And then NORA, NORA, is a group that involves therapists and optometrists looking into vision therapy. So those are two really good resources. COVD
Writing
is
that
the end of the
down.
name,
Yeah.
or NORA.org, I believe. And NORA actually had a really neat international course here last year, and so I got to meet folks from all over the world that were physical therapists, optometrists, etc., and we are all coming together to think about collaborating visually. So yeah, neurooptometry, I think, is just looking deeper into, like you and I do in dentistry and therapy. Why is this person having dysfunction? Is the it could be, again, a client with ADD or dyslexia. It could be someone after a concussion. Certainly that's probably where I think of them the most, seeing someone that's had a mild or any significant traumatic brain injury, um or someone that has, like, strabismus or issues where their eyes aren't focusing well, they're not working well together, so their binocular function is diminished. um, when I think about neurooptometry, these folks are going to be looking a lot like you and all of us do in function, right? So if you go to an eye doctor, they're going to check your acuity, and they'll make sure that you can see 20/20, and that's super important. But most of vision is peripheral, and it's how you perceive yourself in space. So when we think about neurooptometry and physical therapy working together, we want to see that person not just sit behind the thing that, most of us, like, want to push away, right? So you're already an extension when you're getting that test. So be mindful of that. We want to take that prescription, um, put it on trial frames, and then have the patient walk around inside, outside, sense the floor, sense their bite, sense the maxilla is essentially the roof, the floor rather, of the eye. These systems really need to work together. And so neurooptometrists would be looking a lot at the function of vision, how you're perceiving yourself through space, whether you've had a brain injury or not. Could be from birth, like your patient you were mentioning earlier,
Mhm.
Alex.
Mhm.
Or are they just clumsy? Or are they straining a lot? Are that forehead headache still there, even though you've got some of that temporalis tension down? Like your night guard or splint may have helped so much the cranial alignment. But for example, you can get neurooptometrists to consider things. I thought of two quick examples for you both. Myself being one of them, the patient I know the best. I have a very small amount of astigmatism in just my right eye. And no one ever gave me any correction for that because I can see so well. How am I seeing so well? Well, my extraocular muscles are working harder constantly, and my brain is having to work harder to correct my blurred vision that's coming in from my right eye. It wasn't
Mhm.
until I had a concussion that I actually saw a neurooptometrist to look at, getting that astigmatism corrected actually will make your whole head feel better, because now your energy systems aren't straining so much to see clearly all the time. And we have enough brain power, but we don't want to be using that on, is that straight? Is that clear? Is that crisp? Because now you're attending to that and you might be missing left peripheral vision. And that could be affecting, TMJ function quite intimately. So that's one example. And actually, since I don't need a contact, I often forget to put it in the morning, and I'll start to get this little headache come in, and I'll feel that whole mohawk headache kick in because my suboccipitals are working harder, and my eye and cranial muscles are working harder to see clearly. And then I go, oh, I better go put my contact in. So
So
that's
then,
a quick example of someone that could slide under the radar because I could
yeah,
see fine,
yeah.
but at what cost? Yeah.
So then, do you get in and try to like adjust the sphenoid since the ophthalmic artery and nerve travel through the sphenoid to see if it's more with blood flow?
I love your question. I love all this French osteopathic work that I do with the Barral Institute. Often I do. I find that an ideal sequence for someone who needs a neuro-optometry consult would be seeing me and determining if we need to have that person obviously make the appointment, but then having some manual therapy time, yeah, to really dive in and listen into what systems are pulled. I do a lot of dural glides in the occipital region with eye movements, active eye movements, so many optic nerve techniques, and like you said, arterial techniques. So I'm trying to optimize that environment before the person goes in to see the eye doctor. So hopefully they don't need as much of a prescription.
Sure.
Yeah.
Sure.
But a lot of times too, patients will get so overcorrected for central vision. They'll want to see so well. And they may not be looking at like eye dominance, which is
Mhm.
really important. And then again, we're taking away periphery. And that's like walking around with, binoculars
Sure.
on, right?
Sure.
Now you're not noticing your side to side. And so no one's going to laterally deviate well when they're in extension all the time. So
Right.
these things play a big role, I think, in your world. Just even having an eye doctor to look at somebody's gait after they get the prescription locked in. And then, like the dental guards, I'll often have patients come into my clinic and reassess cranial motion, gait,
Right.
and all the passive range of motions measurements mentioned already, and just also give someone a break after an eye exam because it can be a lot on your system.
Yeah.
It's like getting a crown and then going, how do you feel? And you're like, I don't know.
Yeah.
So maybe a day or two later, having them come in and check that script and just seeing, like, do you like wearing these? How does a reader feel for you? So they have a
Mhm.
little more time really sensing, like, I feel really flighty and tense when I put these on. Oh, or I feel grounded. I feel calm. This is a good
Mhm.
thing. I like these glasses. So
Well,
yeah,
I
that's how
think
I work
one
with an optometrist.
yeah, I think one thing too that we need to mention is that not all guards are gonna help. Some can make you worse. Like some mouth guards,
Yes, ma'am.
when I've tested patients, with guards that they've came in with, and I'll look at their EMGs or look at their balance or look at their gait, and then when you put one in that is, neuromuscularly correct, there's a total difference, and they're like, because a lot of times they'll come with 6 or 7 guards and put them down and be like, how's yours gonna be different?" So, I
Yes.
want people listening to think like any guard is gonna work
Oh,
because
absolutely not.
yeah.
Yeah.
So
And then
Yeah.
Dr. Parker always really called them orthotics, right?
yeah,
So
right,
Yeah.
right,
TMJ orthotics.
and
Yeah,
that's what
yeah.
I
So
call them too, orthotics,
yeah,
but
orthotics.
Yeah.
But
patients and people listening call them mouth guards.
I know.
Right.
So what percent of your patients complain of TMJ symptoms to you, or is it something you pick up on as you're talking to them and they're telling you symptoms, or how's that? What do you find there?
I think so many folks, especially the clients I see with hypermobility, have TMD, and it's
I
just
agree.
one of a list of many things.
Mhm.
And, sadly, they've probably mentioned it to someone. Maybe they have a night guard they're going to use better. And so it's a top guard. And I find those really lock up people. I've taken those out of folks' mouths and they've had immediate pain relief, especially in the upper thoracic. So I
Mhm.
rarely see that the maxillary guards are helpful for most people. Again, I know there
Agreed.
are very good reasons why, and that's not my lane, but I generally see most people have some kind of TMD. I would guess over 80%, Alex.
Yeah. Wow.
Um, but a lot of times, yeah, it's just kind of like, I'm going to have to live with it. I mean, I saw a young man yesterday who has a great bite, just finished Invisaligns. He's actually been through vision therapy and has improved his dyslexia. But because of a concussion that hit his maxilla so hard that his canine didn't erupt on the right side, he actually had so much neural trauma that I helped clear yesterday with some manual therapy that he he wasn't saying anything about his head or neck. He came in complaining of a little bit of back pain. But even at like 15, you could see his face, the apathy, the dejection. He's like, my mom's taking me to another therapist, and oh, my back hurts. And I had to, kind of pull teeth, not literally, right? But just try and get some information from him. So as I'm going through and screening his systems, I'm like, what about headaches? And he goes, yeah, I have one all the time. And your heart just breaks. It's like you're an athletic, healthy kid, and you just look like you're ready to. I don't know. So he's someone that, for example, like I think a lot of folks just they just put it in the back burner. If I say something, they're going to think I'm nuts. Maybe my bite's fine, right? And so the hypermobile people and the folks that have had trauma where their bodies have compensated, like this young man, I think are perfect examples of how PRI can really help. It's not just manual therapy. It's not just orthopedics. It's looking at what the body did to basically layer on additional compensations. And so even if they look neutral and their measurements are negative, you look fine. What's wrong with you? We can know that those
Mhm.
patterns are still underlying neurologically, and we can help assess what that driver is then, whether it's going to a dentist or maybe not. Maybe it's vision, maybe it's just some good exercises, maybe it's manual. A lot of times for my patients, it's all. But I would say most people have a strong degree of TMD issue. And so many folks with TMJ clicking, they just go, oh, well, it's gotten better. And you're like, how's it,
Yeah.
the quieter it is, usually that's right, further compensation. So I have to be really careful how I phrase that. But it's like, well, that's not necessarily good that it doesn't click as much anymore. So yeah, like not scaring folks, meeting them where they are, really
Yeah.
listening, and then trying to help realize what can we do to triage you to the right people,
Sure.
just to get a good team again,
Yeah.
and a team like Dr. Mystery and other good dentists in our area who care and who take the time to really dive in, what's going on, what can we help you with? So
Right.
yeah, to answer your question, a lot more than I think you would know. And
Right.
same with vision, frankly, Alex. I think so many people just go get your eyes checked by a high level person, someone that's going to give you a lot of time and consideration. And you may not need anything, but at least we've ruled that out.
Sure.
So
Sure.
I had not to bring it back to the neuro-optometry part of it, but it's very interesting because today, before this, my son had an eye appointment. So he has astigmatism in his left eye.
yeah.
And, from when he was very little, they caught it. But it's hard to take, like, a two-year-old to the eye doctor because 'cause they're not gonna cooperate, right?
No.
So, now he's 7. He just turned 7. He's had glasses for a little over a year. And when he put those glasses on last year,
Mm.
he was like, "Oh my god," like he could see, right? We didn't know. And so we
Wonderful.
took him out. I said, "What do you?" Because I remember getting glasses at 8, and I could see the leaves on the trees. It didn't just look like blurry blobs of
Yes.
green, right? So I took him outside and I said, "What do you see, honey?" And, like, thinking he was gonna say something like, "I see the leaves on the trees," or something
Yeah.
detailed. And he said, "I see that car and that car and that car." And I was like, "Okay, you could see those cars before." But he was just so cute. He was so little, right? But my point is today, so he had an exam at his elementary school a few weeks ago, and they said even with his glasses on, he's not seeing as well as he should. So his vision got
Mm.
worse. So we took him in today and they did change the prescription, and, our functional orthodontist dentist guy noticed that, his
Oh,
left eye
Dr.
doesn't
Kim?
convert. Huh?
Dr. Kim?
I love him. Dr. Kim,
I
yeah.
love him too. I'm so glad
I
he's
love
with
him.
your practice. Yeah.
So great. You gotta meet him. But he was
Oh, I have.
noticing
Yeah.
even a year ago that oh, okay, you have that Rohan, my son's left eye doesn't, converge as you bring your like, the same way the right one does. And so I was pointing this out to the optometrist today, and he was just like, "Well, it seems okay," kinda like brushing it off, and I said, "Okay, well, are there exercises we can do to help him with that?" And then he told me about, like, this thing you can buy on Amazon, I don't remember what it's called, and you can do these exercises to help with the convergence of the left eye, but my whole point of saying all this, I'm just rambling at this point,
No,
is
you're good.
we wanna bring him in to see you and just kind of get your thoughts, and it was funny 'cause, Alex, I don't know if you know this, but Emily and I both spoke at this, conference about a week ago. It was just a 6 PM to 9 PM, like, networking thing where, like,
Yeah.
I think there were 4 or 5 speakers. It was
Yeah.
me, you, there was a big ENT in the area, a bunch of different people, but, my husband was there, and my husband is the most, like he's pretty skeptical of, like, everything, but after he heard Emily speak, he's like, I'm gonna go see her for myself." And he's like,
Yeah.
And I said, "Okay, what do you wanna see her about?" He's like, "I just want her to tell her what's wrong with me." I was like, "He just wants a whole assessment." And I was like, "We should
Good.
all go." We should all just go and get an assessment. So that's our plan, Emily. We're going to invade your office.
Absolutely. It's heartwarming to hear that. I want to go back to astigmatism too, but so many people, I think of us dentists and PTs, like, well, let's go when we have a cavity, or let's go when we're injured, or
Right.
post-operatively. We have, and I actually use the dental screening times often to remind patients, like, how often do you go to the dentist? Twice a year. Come check in. Like,
Yeah.
I don't want to find something wrong with you, but if there's something that's a quick treatment, a couple exercises we could update, maybe you added in some weightlifting or running that is like tweaking your back. Let's just huddle up about that, and let's get ahead of it so it doesn't turn into something like preventative medicine, right?
Yeah.
Medicine 3.0. Um, but Ron will speak to astigmatism as scoliosis of the eye.
Oh,
And
wow.
so, speaking to cranial nerds
Ah,
here
I'm
in
gonna write
this
that down.
group, so much of that torque shows up in
Yes.
astigmatism and in the lens itself. And so I love doing any kind of osteopathic technique that is needed to help the eye function. Because sometimes, yeah, you could do convergence exercises. Frankly, those are often overdone, and without the guidance of a vision therapist or a neuro-optometrist, you can overdo those. Post
Yeah, I
concussion,
don't
that's
want to.
very
Okay.
common. And again, my little 3-year-old brain would go, "Why is only his left eye not converging?" Right?
Mhm.
And so, is there something structural? Is that something with some of the patterning? And then once you've cleared those things out, right? Structure is aligned, the person's more neutral, they're in a better autonomic state. Maybe there is just some very simple vision therapy intervention. But I really like to try to clear as much as I can out for my colleagues. So, yeah, they're no offense not driving to Vancouver five
Right.
months out of the year. I'm teasing. But what can I do as a physical therapist to optimize their environment and get their structure and alignment and orientation in space, to the ground, to the earth, to
Yeah.
what's around them, as neutral as possible. And then that'll make hopefully my colleagues' jobs easier and vice versa. So, but yeah,
Yeah, I'm
astigmatism in the
so.
eye is a really fun thing to think about. What's that torque? Where's the sphenoid doing, right, Alex?
Yeah.
Right.
What are these systems that are driving that? And we
Right.
could just keep going to the eye doctor and correcting it. That's fine. That may be the only thing we can do. But I always like to ask, is there anything else underlying that's driving?
Yeah. Well, I mean, I've seen patients, their eyesight has got changed through TMJ treatment, right?
Absolutely.
Because everything's
Yeah.
connected. And then,
Yeah. I've seen
um,
that too. Yeah.
yeah.
With astigmatism, if you've had astigmatism, like say for 50 years, say you're in your 50s and you've had it since you were a child, like Priya's
Yeah.
kid, can you like make it a little bit better even though you're that old?
Yeah, I think one thing I'll piggyback off of what you're asking, because I think you can. I think I'm not in this field enough to know, but I know it can worsen,
In your
certainly.
opinion.
Right. I think too, I'm not going to be like, oh, by the book that says you don't need to wear glasses. That's not what I'm saying.
Yeah.
But I think if you continue to match that, like, you might be asking more and more of like distance vision for
Hopefully.
that eye. Quick example. In the postural restoration asymmetrical patterns that everyone has, we tend to be more right lateralized, pelvis oriented to the right, more weight through the right leg. The rotation of the trunk is going to counter that, and the rotation of the head is going to counter that. And what that does is it makes the left eye more dominant and the right side more aware of the periphery, because you're over to the right
Wow.
of center.
Okay.
So if I'm a right eye dominant individual, which I am, and I'm turned like this, and I'm noticing my right side, I'm going to have to counter rotate my head to try to orient now my dominant eye into my center of what I'm, reading, speaking to, looking at, whatever. So that's just going to invite additional torque. So even thinking about what eye is centered and dominant, which side's peripheral, can I switch that? Not that I would switch eye dominance necessarily, but just be able to weight shift and then keep my visual center, right, balanced. So back to astigmatism, I think what we often do as well-meaning providers is we might, as an optometrist, for example, might give that person more and more clarity or acuity, and increasing their astigmatism power, and that's a cylinder. And so if you keep making that that visual prescription more and more crisp, you're
Yeah.
now giving that eye so much central dominance that you could create an imbalance in how the brain is even working with the binocular function, if that makes sense. So
Wow.
in that way, you could be feeding into the nervous system's need to try to see better. And so that's where even in optometry, I think if, colleagues were here that had more background than I do, we could say, when do you want a little blur? When do you not want that one side to be so crisp? Like at a young age for your son, where do we just go, okay, this is good enough? And what's really fun about my job is I can put in my trial lenses in my trial frames and we can play with that. And since a cylinder obviously has an axis too, we can play with where the axis is. And even a couple degrees of rotation can actually soften the tone in the body. So sometimes astigmatism, given that it has two variables, both the power, as it were, the cylinder number, and the axis it's on from 0 to 180, those two variables can allow for some kind of playing with, again, under the guidance of an optometrist, obviously, and within their parameters, certainly, but maybe not having that person be overcorrected and then seek more. So each year they want more and more, when in reality that might be heightening a lot of TMD and headache and other body symptoms. It might be pulling them basically off of their grounded center and making them have more anxiety, for example, or clenching. So it's really neat how they're all related. But yeah, astigmatism is something I always go, how much should we be correcting for? But I've had folks with headaches that, you give them a quarter sil and their headaches go away because that little bit of correction is all they needed. And that's not something that's generally prescribed. So everybody's different. We always have to be checking our clients, obviously, but astigmatism is fun variables, along with sphere, certainly, the power of the two plus or minus lenses. And then what neuro-optometrists do that I should mention is they often add in a prism if there's more of a need for that, which I would say ophthalmologists and most optometrists would not generally be comfortable with prescribing. And those are usually used very short term, but they can vary where you are in space. Converge or diverge or have a vertical shift corrected. And so prisms can be really, really wonderful adjunctive tools short term to help a person feel more grounded or have their eyes work better together, for example. And that's where a neuro-optometrist would be someone that you could help with. So many times people just have a head injury, it's minor, and they keep going, and just that simple lens adjustment might give them, 3 months of therapy, and then their whole system can realign and get back to a good baseline. So really good people to know. I highly recommend getting to know your local neuro-optometrist.
Yeah. It sounds like I have one right across the way. I haven't met them yet. So.
You do.
Yeah, I need to get over there. But thank you so much for taking the time to chat with us. I feel like I always learn so much from you, Emily. I'm just lucky to have you here.
Likewise. Thanks for having me. It's great.
Thank you, Emily. And thanks to our wonderful audience. And thanks so much for watching. And stay tuned for more episodes from Unclenched. And you can follow Priya and I on our social media. I'm Pittsburgh Dentist. And you can find me on Instagram, TikTok, and YouTube. And then, Priya, you want to give out your info?
Yeah, I'm the_TMJ_doc. Yeah. So you can find me on all the things too. TikTok, Instagram, YouTube, all the things. And then, Emily, are you on socials?
I'm not anymore. No, I just keep a website presence, shinephysicaltherapy.com. So
love it. Well, thanks so much. And you guys, for our wonderful audience, we'll see you next time.
Bye-bye.